Good evening. I'll go straight to the topic, and I'm sorry I would have to cut short to 10 minutes. So my topic is advances in treatment of ANCA vasculitis. I thank the organizers for calling me. So sorry because it's in a hurry. We all know ANCA vasculitis actually involves the small-sized two, small-sized arteries up to the veins. So you can have small-sized arteritis, you can have capillaritis, you can have venulitis, and all of them can be involved. And what is characteristic about ANCA-associated vasculitis? That it is associated with these ANCA antibodies. So this was a classification which was actually put forth in Chapel Hill Consensus Conference in 2013, and it still holds true as far as ANCA vasculitis is concerned. So it's important to know what is the spectrum of disease severity, because ever since the guidelines have been put forth for the treatment of ANCA vasculitis, it is the severity of disease which guides the treatment. So you have the potentially organ or life-threatening manifestations, which includes glomerulonephritis, pulmonary hemorrhage, meningeal involvement, central nervous involvement, retroorbital disease, which is threatening the eye, cardiac involvement, mesenteric ischemia, and mononeuritis multiplex. Also added to this is if there is an organ-threatening scleritis. The other manifestations, which are basically nasal disease, skin manifestation, the skeletal muscle involvement alone, pulmonary involvement in the form of non-cavitating pulmonary nodule. So not the pulmonary hemorrhage. Pulmonary hemorrhage comes in the severe disease and episcleritis. So they are considered as the known organ or life-threatening manifestations, and they have to be treated in a similar way. So what are the goals of treatment? So if you ask me the advances in ANCA vasculitis, one most important thing is that people are very clear nowadays as to what their goals should be when they manage these disease. So the goals, basically, you have to induce remission. Once you have induced remission, you have to tackle the relapses, because the relapses are fairly common in ANCA vasculitis patients. It ranges up to 50% by 5 years. But having treated remission and relapses, you have to be very sure that you reduce the treatment-related morbidity and finally improve the quality of life and patient survival. So what I would be discussing in the next 10 minutes is basically the different guidelines which have come forth in the past 2 to 3 years, wherein they have updated the guidelines in accordance with the evidence. So we look at the guideline and then we go to the evidences behind those guidelines. So it was in 2015, actually, EULAR, that is European League Against Rheumatism, and the European Dialysis and Transplant Association had put forth the guideline for the management of ANCA vasculitis, which again has 2 phases. One, you have how do you induce remission, and then how do you maintain the remission. So induction of remission basically dependent on if you have a known organ-threatening disease, which could be managed with methotrexate or mycophenolate along with glucocorticoids. So basically glucocorticoids is first line along with these 2 second line agents. If you have an organ-threatening or a life-threatening disease in the form of rapidly progressive renal failure or pulmonary hemorrhage, you treat the patients with either cyclophosphamide or rituximab with definite high-dose glucocorticosteroid amount into pulse therapy. And you may consider plasma exchange in these patients who have RPGN or pulmonary hemorrhage. The patients who are refractory have to be treated in a different way. Whereas the patients who have undergone remission, you have to maintain the remission by giving a second-line agent, which is generally azathioprine or methotrexate or rituximab, along with tapering doses of glucocorticoids. So you just have to look at this guideline in detail. And then at 2 years, you can consider tapering or stopping the immunosuppression. So what has changed? Now there is an update in 2022. So what is the change? Basically, when you look at the remission, that is the induction of remission, nowadays there is another drug which has come into picture, which is known as avacopan, which is considered as a way to basically get away with steroids in ANCA vasculitis. Rituximab has found its place it has become a dominant drug as far as induction as well as the maintenance of remission is concerned in patients who have the severe organ-threatening disease. Whereas non-severe disease, methotrexate and mycophenolate have taken a little back step, whereas rituximab, along with glucocorticoids, has basically come into the forefront as far as the maintenance of immunosuppression is concerned. Now, in the non-severe disease. Now, when it comes to the maintenance, if you see the change, actually, in the earlier, rituximab was not considered to be a front drug in case of when it comes to maintenance of remission is concerned. But now the rituximab has actually become almost like an anchor drug in the maintenance of remission in the patients who have both severe organ-threatening disease or a non-severe disease. However, there are situations where you can try azathioprine, methotrexate, or mycophenolate. So first, look at the induction. What is the change that has happened over the last decade as far as the induction agent is concerned? So you have a clarity on situations wherein you can use rituximab as a preferred agent as compared to cyclophosphamide. Avacopan has made its way as one of the drugs which is given in lieu of steroids in patients with these conditions. Then there is always a move towards going low on the dose of steroids and what has happened to plasma exchange. So when it comes to rituximab or cyclophosphamide, this is all based on most of the post hoc analysis of the two main ANCA trials in the induction treat of ANCA vasculitis, which are RAVE and rituximab trial. Both these trials had compared rituximab versus cyclophosphamide in inducing remission in patients with ANCA vasculitis. So what the post hoc analysis suggests is rituximab is a preferred agent when you have a relapsing disease, which is severe. And in the patients who are younger because of the fertility issues with cyclophosphamide, and even in patients who are older and who are not able to tolerate cyclophosphamide. The patients who present with leukopenia or thrombocytopenia are generally, rituximab is preferred over cyclophosphamide because of the bone marrow suppression induced by cyclophosphamide. Patients with urinary problems, urinary retention, malignancy, history of infections, you prefer rituximab over cyclophosphamide. Whereas you consider cyclophosphamide in patients who have very severe disease and have intolerance to rituximab. They have worsening severe disease in spite of rituximab, and you have a fulminant disease where you would not want to take a chance and you would like a time-tested drug who are requiring mechanical ventilation, etc. So this guideline is basically, it is come up in the American College of Rheumatology Vasculitis Foundation guidelines, where they conditionally recommend rituximab over cyclophosphamide for remission of induction in patients with active severe disease. So second change in induction is basically avacopan. So what is avacopan? First, we should know. So it is basically it's an antagonist, or it is a blocker for complement fragment C5a receptor. And it found its way in ANCA vasculitis by, basically there were in 2007 to 14, there were a series of experiments wherein it was shown that in animal models of ANCA vasculitis, this blocking the C5a and the complement pathway actually led to a reduction in necrotizing glomerulonephritis. This was followed by 2 phase 2 trials, which is CLEAR and CLASSIC trial, which I will not be discussing. And you have a phase 3 trial, which is an ADVOCATE trial. So just going to ADVOCATE trial in brief, this basically a trial, it was, the trial recruited around 300 patients, in which these patients had across the severity range from non-severe to severe disease. The baseline therapy was again oral IV cyclophosphamide or rituximab along with methylprednisolone pulse. But the difference was in the intervention arm, avacopan 30 milligram twice daily was continued over a period of 1 year, along with a rapid taper of glucocorticoids. So the glucocorticoids were essentially stopped by 4 weeks, that is a month. Whereas in the placebo arm, you did not have avacopan, but the rest of the drugs remained the same. And what they found is that clearly avacopan was better as compared to prednisolone only regime in achieving the remission. So by week 26, 72% of the patient in avacopan group achieved remission as compared to 70% patients in prednisolone group. So this was a non-inferiority trial. So basically, it met the non-inferiority margin. And when they looked at the 52 weeks, though it was not a superiority trial, they found that avacopan did show superiority as compared to prednisolone. However, by whatever the primary outcome, we can say avacopan was non-inferior to it was basically better. It was non-inferior to the standard dose of to prednisolone taper alone in patients with ANCA vasculitis. Now, what about the side effects? The side effects were actually more, 53% higher in the standard of care arm as compared to the avacopan arm. And that was because quite a lot of these patients required repeated dose increase in the dose of steroids, and the mean dose, the cumulative dose of steroid was higher in patients who were in placebo as compared to avacopan. So that is how, after that, this drug got FDA approval for use in patients with ANCA vasculitis. Induction of remission in ANCA vasculitis. Now, what about plasma exchange? So as you know, in 2015 guideline, plasma exchange was considered as an add-on therapy in patients who had presented with rapidly progressive glomerulonephritis and the pulmonary hemorrhage. But in this trial, this was Plexiva's trial, it was a very elegantly done trial of 700 patients with ANCA vasculitis, and it was a 2:2 factorial randomized control trial, wherein you had many subgroups of patients, that is the patients with reduced dose glucocorticoid standard dose glucocorticoids, then patients who received on top of that plasma exchange, adjuvant plasma exchange or no plasma exchange. Just in the interest of the time, I'll just come to the primary endpoint. So when they looked at the primary composite endpoint, they found that the proportion of patients with event, which was either going for ESRD or death or any other pulmonary hemorrhage. So basically, it was same in patients with PLEX as compared to the patients who had not received PLEX as an adjuvant therapy, thus sealing the case that PLEX may not be therapeutic, it doesn't have either a survival benefit, it doesn't have any benefit in preventing the end-stage renal disease. And this trial was well powered to look at the various subgroups. And they found that irrespective of whether the patient had received high dose steroids, low dose steroids, whatever group they belong to, this drug, the plasma exchange, did not show any benefit. Now, there were a lot of post hoc analysis of this trial, and one beautiful analysis was that they looked at what was the difference between the patients who received reduced dose as compared to the patients who received higher dose of steroids. And they found that both the reduced dose and higher dose of steroids actually fared equally well, meaning to say you can reduce the dose of steroids. However, all is not what is shown in the trial. When you look at the supplementary table, you realize that the patients who had kidney events in the patients who had low dose steroids was actually the kidney events much higher as compared to the patients who had standard dose of steroids. And followed by this particular abstract, which is present in the recent, in just last year's ACR, wherein again, the authors, they showed that the patients who had received the reduced glucocorticoid regimes had basically a significant higher rate of event as compared to the patients who had received high dose steroids. So we do not know actually when should we go low on steroids and when should we follow the standard practice of giving the high dose steroids. Now we just, in 5 minutes, we'll just finish what is the change which has happened in maintenance therapy. Now, most of the change which has happened in maintenance therapy is in the form of, is basically in the use of rituximab. And all the trials are basically, they are conducted by the European group for vasculitis. So these trials, they were a series of trials. There were 3 trials in a series. One is the main RITSAN trial, where low-dose rituximab 6 monthly infusions were compared with azathioprine. And what they found was that relapse-free survival at 5 years, at 28 months, as well as an extended survival at 5 years. Both ways, basically the relapse-free survival at 28 months was better in rituximab as compared to the patients with azathioprine. Now, this basically, the trial has a long 5 years follow-up. So when they looked at long 5-year follow-up, what they found is that the rituximab patients relapsed because most of these patients stopped rituximab after the 3 doses of taking rituximab. So having to said, rituximab does prevent relapse, but you have to keep on going on with the drug till the for long, we do not know. Then was Mainritsand 2, which basically, I'll just skip this. It compared the 2 regimes of giving rituximab. Either you give on-demand rituximab or you give as a standard protocol of 6 monthly infusions. And they found basically it was a negative trial. Both fared equally well. I'll not go into the appraisal of the trial because all these trials have been actually looked at in great detail and we have learned a lot from these trials. Then the question was, if you, okay, fine, rituximab works, it is better than azathioprine, but how long do we continue? Is 2 years enough? So this was answered by 3 trials. One is a REMAIN trial, Mainritsand 3 trial, and it is a REM phase 3 trial. My apologies, I cannot discuss this in detail, but I'll just give you the snapshot of the Ritasaram trial, which is the latest trial, wherein the patients were given, they were induced, these are all patients who had relapsed on their induction agent, were induced with rituximab and then followed by 4 monthly rituximab infusions. And what they realized is that, so this is basically continuing rituximab as compared to azathioprine. And what they found is that clearly the relapse-free survival was better in patients who had taken rituximab. But again, it was the same thing. You stop rituximab. If you stop rituximab, then again you relapse. So meaning to say that you have to probably continue rituximab definitely more than 24 months of treatment. Then this is the last trial, which actually it's a Mainritsand 3 trial, wherein the patients who were enrolled in Mainritsand 1 and 2 trial, they basically were given added on infusions of rituximab for up to for another 2 years. And what they found is that the patients who had continued rituximab definitely fared better as compared to the patients who had stopped rituximab at 2 years. So meaning to say, at least for 4 years, if you give rituximab, it is probably better as giving for 2 years. But there are a lot of cash to it, which I cannot discuss at this point in time. What about the adverse events? They were fairly similar, meaning to say that you continue the drug and you continue it for up to 4 years. Can you discontinue maintenance rituximab? So this is again, I always feel the trial data has to be supported by various real life setting. So this is a very elegant retrospective single center study of 141 patients by Ronak Smith's group. And they try to figure out what are the prediction models which identify the risk for relapse. And also they identify the risk for infections at 2 years, meaning to say, who are the patients who will benefit from giving the extended dose. And what they found is that the patients who had the ENT involvement while on rituximab and the patients who continued to have or became ANCA positive after being ANCA negative, they are the patients who relapse the most. And for them, probably you have to continue for long. When they looked at the infection rates, they found that the patients who have structural lung disease have concomitant diabetes, and those who had infection during rituximab are more likely to develop infections while on maintenance therapy. So probably you need to establish a balance. Now this is basically, ideally I should not be presenting, but because it is a home front, can you taper rituximab rather than continuing rituximab for long? So this is a small study. It's an ongoing study, which we are doing in our department. Currently, it's a multi-center study, wherein we have already recruited 33 patients, and preliminary analysis shows that whether you can reduce the dose of rituximab, and it is going to have a good relapse-free survival, at least for the first 1 year is what we have analyzed. The study is ongoing. So this is the take-home. That what are the advances? Rituximab, it has found its place as a first-line induction regime in a subset of patients with ANCA vasculitis. The PLEX trial results do not support its use in severe AAV, but there are real-life settings wherein they support the use of PLEX conditionally in patients who have a rapidly progressive glomerulonephritis. You can go on low on steroids, but it may be feasible only in a subset of patients. There is a new drug, avacopan, which is like a panacea for steroids. But it's very early to say how this drug is going to be effective in patients without steroids. And having said that, the Canadian Society actually hasn't given a go ahead to this drug. They have not approved the drug because they found that the cost and benefit ratio is much, it is not supporting the use of this drug. Maintenance, rituximab is better than azathioprine. The discontinuation of immunosuppressants still remains a dream. Lower doses of rituximab may be an alternative. We are yet to get a good data on that. And you have now better strategies to balance infection risk and relapse risks in these patients. Thank you.